So, hola everybody, my name is Andrea Gispe. I'm from Universidad de Ingeniería y Tecnología from Lima, Peru. I am here to present the study Find Particular Air Pollution and Childhood Pneumonia in Lima, Peru, a district level ecological analysis, 2015-2023. First, let me start with a key clarification. This is not a pneumococcal specific study. We did not measure pneumococcal pneumonia, serotypes, or microbiology confirmation. However, this is relevant for ISPPD because it examines an upstream determinant of pneumonia burden, fine particulate air pollution, or PM2.5, in a highly polluted and unequal Latin American city. Our central question was if higher PM2.5 exposure associated with higher type of pneumonia rates across districts in Lima, Peru. So here are my disclosures. So type of pneumonia remains the major cause of morbidity in low and middle income segments. In conferences like ISPPD, we usually focus on pathogens, vaccines, antimicrobial treatment, and clinical outcomes. All of that is essential, but pneumonia doesn't occur in a vacuum. Children develop disease with environmental and social context. PM2.5 is relevant because these particles can penetrate distal airways and may contribute to airway inflammation, epithelial dysfunction, oxidative stress, and impaired respiratory host defense. So the key point is this: air pollution is not the pathogen, but it may shape vulnerability to infection, severity of disease, and inequities in pneumonia burden. So what is valid for ISPPD? Because pneumonia prevention is not only about pathogens and vaccine, it is also about understanding who becomes vulnerable when cases surge and where burden concentrates. In polluted urban settings, PM2.5 may interact with host vulnerability through airway inflammation and impaired innate immunity. At the population level, this may translate into an equal pneumonia burden across districts. Again, we are not claiming pneumococcal causality. Our point is that reducing pneumonia burden requires looking beyond the pathogen and including environmental determinants. So, the objective was to estimate the association between weekly district level PM2.5 exposure and childhood pneumonia rates in 7 districts of metropolitan Lima from 2015 to 2023. On the left, you have the 7 districts included in the analysis. These districts were under environmental surveillance by CENAMI, Peru's National Service of Meteorology and Hydrology. On the right, the figures show PM2.5 trends over time. The red horizontal line represents WHO daily guidelines for PM2.5, 50 micrograms per cubic meter. Several districts remain above that reference level. The figure also separates the pre-COVID, COVID, and post-COVID periods because the pandemic changed mobility, surveillance, care seeking, and respiratory disease dynamics. We conducted a longitudinal ecological analysis using district width as the unit of analysis. The outcome was weekly all-case childhood pneumonia cases from Ministry of Health surveillance data. The exposure was weekly PM2.5 concentration from CENAMI environmental monitoring. We used a negative binomial regression model appropriate for an over-dispersed count data. The model also adjusted for time, seasonality, district, and include district child population as an offset. The graph on the right shows weekly pneumonia cases over time. The COVID period is clearly visible, but we interpreted it cautiously because change may reflect not only transmission, but also healthy access, notification, mobility, viral circulation, and exposure patterns. That is why temporal and seasonal adjustment was particularly essential. So, the main findings. PM2.5 was positively associated with childhood pneumonia rates. The adjusted incidence rate ratio was 1.03 with a 90% confidence interval from 1.02 to 1.04. This means that each 1 microgram per cubic meter increase in weekly PM2.5 was associated with approximately a 3% higher childhood pneumonia rate after adjustment for time, seasonality, district, and child population. The following plots on the right also show a strong district level heterogeneity. Compared with San Borja, which is a high-income district, several districts had substantially higher pneumonia rates. The highest adjusted borders were observed in San Juan de Lurigancho and San Martín de Porras, districts with greater socioeconomic vulnerability and high urban density. However, these district differences should not be attributed only to PM2.5. They likely reflect combined environmental, demographic, socioeconomic, and health system factors. So the main message here is this. PM2.5 was associated with pneumonia rates, and pneumonia burden was deeply unequal across districts. So what this study asks the pneumonia research? First, it provides local evidence from a highly polluted Latin American urban setting. Second, it shows an ecological association between PM2.5 and sulfur pneumonia rates. Third, it highlights a strong district-level heterogeneity in pneumonia burden. And fourth, it supports integrating environmental surveillance into pneumonia prevention. For ISPPD, the implication is particularly clear. Pathogen-specific surveillance remains essential, but it should be strengthened with environmental and pollution level surveillance. This study has several important limitations. First, it is ecological, so associations were not estimated at district level, not individual level, so we cannot infer individual risks. Second, the outcome was all-cause sulfur pneumonia, not laboratory-confirmed pneumococcal pneumonia. Third, we lack individual data on vaccination, viral infection, nutrition, indoor pollution, crowding, and socioeconomic status. Fourth, district-level PM2.5 may not represent personal exposure. Finally, COVID-19 likely affected surveillance, care-seeking, mobility, and respiratory transmission. So, overall, the interpretation of the result must be extremely cautious. We are not claiming pneumococcal causality. We are reporting a statistically significant ecological association between PM2.5 and sulfur pneumonia rates in an urban setting with major environmental and social heterogeneity. So, the take-home message from O'Hara's to you is this one. Cleaner air should be part of the pneumonia prevention agenda. Integrating environmental surveillance with pneumonia surveillance can help identify vulnerable districts, guide prevention, and strengthen preparedness. I would like to thank the final presentation, my co-authors, you, the ISPPD, and the Bill and Melinda Gates Foundation for the opportunity to present you on the study today. Thank you very much, and I'm happy to take your questions.